All right, hi, my name is Vanna Albert. I'm one of the emergency medicine faculty here at Baystate Emergency Department. One of my interests is administration. I did an administration fellowship here and stayed on as faculty, and also working on some health equity initiatives. For today, we're going to be talking about thyroid emergencies in the emergency department. All right, so the goal of this talk is we're going to do a brief review of the pathophysiology. We're not going to go into too much detail. And then we're going to touch base on the high yield topics for hyperthyroidism, which include things like thyrotoxicosis and thyroid storm. And then we're also going to talk about some of the hypothyroid emergencies that we don't want to miss in the emergency department, which include, things like MYXEDEMA crisis/coma and symptomatic hypothyroidism. So the first thing we're going to talk about is just going over the brief pathophysiology that we all learned in medical school. So just in general, we're going to start off with the hypothalamus. The hypothalamus is actually what sends signals to the pituitary gland via the thyrotropin releasing hormone. From the pituitary gland, then the pituitary gland releases TSH, and TSH then acts on the thyroid gland, which stimulates it to produce T3 and T4. T4 is solely a product of the thyroid gland, whereas T3 can actually be converted from T4 to T3 in the tissues peripherally. And then in general, in terms of the negative feedback mechanism, when there are elevated levels of T3 and T4, that causes a negative inhibition at the pituitary gland, causing a decrease in TSH, and also inhibition at the hypothalamus, causing a decrease in thyrotropin releasing hormone. And just in general, as I may have mentioned before, T3 is the active form of T4. All right, so first thing we'll talk about is hyperthyroidism. So in general, whenever we refer to hyperthyroidism, we're talking about excess circulating hormone from the thyroid gland hyperfunction. And so when we're thinking about primary hyperthyroidism, we're thinking about more production from the thyroid gland. Whereas when we think about secondary hyperthyroidism, we're thinking about excess production of either thyrotropin releasing hormone from the hypothalamus or excess production of TSH from the pituitary gland. And here in the United States, the most common cause of primary hyperthyroidism is Graves' disease, which accounts for about 85% of all cases in the United States. And with Graves' disease, that's caused by thyrotropin receptor antibodies that stimulate excess and uncontrolled thyroid synthesis and secretion of thyroid hormones. The second most common cause is actually the multinodular goiter in terms of other causes for primary hyperthyroidism in the United States. And then other causes of hyperthyroidism that are essentially not necessarily related to the thyroid gland, but non-thyroidal disease include things like ectopic thyroid tissue from a teratoma, metastatic thyroid cancer, hydatidiform mole, and then we think about drugs are common causes. Things like amiodarone, iodine, or excessive thyroid hormone ingestion can cause it. So when we're thinking about the basic lab findings or even diagnosing it with lab findings, when we think of primary hyperthyroidism in general, we think that they'll usually will have a low TSH as well as an elevated T3 and T4. However, oftentimes, at least in our department at Baystate, we'll get the TSH first before we get the T3 and T4. And I think a caveat to know is that a low TSH is not necessarily diagnostic of hyperthyroidism. The reason why is because low TSH can be caused by a number of things. It can be caused by chronic renal disease, chronic liver disease. Even glucocorticoids actually can cause a decrease in TSH because it can reduce the secretion of TSH. So just as an aside, TSH alone is not enough, but you do also need to get the T3 and T4. And then general, we'll diagnose, hyperthyroidism more so with a low TSH and an elevated T4 or elevated T3. Whereas with secondary hyperthyroidism, TSH is actually the opposite. It's increased because of increased production in the pituitary. So now we're going to kind of talk about more just some of the general terms. So differentiating hyperthyroidism from thyrotoxicosis. So with thyrotoxicosis, we're talking about excess circulating thyroid hormone originating from any cause, not just excess thyroid hormone from the thyroid gland. And thyrotoxicosis can be caused by a number of things. Some of the things that are not commonly thought about are things like subacute thyroiditis, and that's where you have like a painful gland that is firm and hard to palpation, and the ESR could be elevated with that. You also painless thyroiditis is also another cause that we may not think about as often, and you'll actually want to think about that in patients who present postpartum within the first year after childbirth. And then some of those patients who have painless thyroiditis, they may have a family history, or they may have like an autoimmune thyroid disease. And so now the next term we want to define at least is thyroid storm, and differentiating that between thyrotoxicosis. And thyroid storm is actually the acute life-threatening metabolic state of thyrotoxicosis. And so with thyroid storm can be precipitated by a number of things, and a lot of times it could be anything that we would see in the ED. Things like infection, trauma, diabetic ketoacidosis, withdrawal of antithyroid medications, thyroid gland palpation, ingestion of thyroid hormone, MI, strokes, PEs, anything we can think of. Less common causes actually is what we mentioned before, things like thyroiditis, which could be painful or painless. And another thing to think about are pregnancy considerations. So there are times where we'll have patients who come in the first trimester, and they come in with what we're familiar with to be hyperemesis gravidarum. And a lot of times these patients could present with signs and symptoms of hyperthyroidism, which include things like weight loss, tachycardia, and vomiting. And they may even demonstrate laboratory evidence of hyperthyroidism, which is actually likely due to thyrotropin receptor stimulation from HCG serum concentrations. And so typically we would count that more as transient hyperthyroidism, where TSH may be suppressed, but you might have free elevated T4 and a T3 that's lower than normal, or at least lower than you would expect in true hyperthyroidism. In general, if you do see a pregnant patient who has hyperemesis gravidarum, for the most part, the treatment is going to be supportive. You're not going to be treating them as a true hyperthyroidism. Whereas when you're looking at true hyperthyroidism and you're comparing like the lab values that you would see in hyperemesis gravidarum versus someone who truly has it, you would expect their T4 and T3 to both be elevated. And that's something that you would definitely want to treat. True hyperthyroidism can definitely cause increased risk of preeclampsia, low birth rate, as well as possible congenital malformations. So it's important to know the difference as to when it's transient hyperthyroidism versus true hyperthyroidism. So signs and symptoms, it's actually really a spectrum when you're thinking about hyperthyroidism, thyrotoxicosis, as well as thyroid storm. So in general, when we're thinking about hyperthyroidism and thyrotoxicosis, you'll often see an overlap in the symptoms, things like lid lag, tremors, they might be agitated, they might have some exophthalmos, palpitations, they'll often be tachycardic. But I think the thing to differentiate hyperthyroidism, thyrotoxicosis, and thyroid storm is more so focusing on the CNS system, thermoregulatory system, and GI system. So when we're thinking about thyroid storm, which is the extreme version, the life-threatening cause that we don't want to miss, we think first about the thermoregulatory system, where most of the times they'll have fever. Then we think about the CNS system, where oftentimes they might be agitated, but they may also be in a coma. They may also be delirious, or they'll have extreme lethargy. Then we think about like the GI system, whereas in thyroid storm, they might have nausea, vomiting, diarrhea. They might have jaundice as well. So just in general, when you're thinking about the signs and symptoms, think for thyroid storm more of like the extreme version, which is the one who you would think more so would be the ones that you're thinking about going to the ICU or the step down or intercare. So when working up these patients, for the most part, a lot of these patients are undifferentiated. You may not have any of your thyroid, testing back. So you're gonna most likely order the tests that you would normally order. Things like your CBC, you'll order electrolytes or your glucose, you may even order LFTs. One thing to think about if you are suspecting, thyroid storm, is that when you're looking at your labs, they may be hyperglycemic. And the reason for that is that it's secondary to catecholamine-induced inhibition of insulin release, as well as increased glycogenolysis and also rapid absorption of glucose. Other lab values that you want to watch out for when you're thinking about, hyperthyroidism or thyroid storm is they may also have mild hypercalcemia, as well as an elevated alk phos, and that can occur because of hemoconcentration. So those are a couple things. So you would be getting your typical labs, but pay attention more to the glucose and try to make sure you at least get some LFTs, check their calcium, and then EKG, chest x-ray. And then for the most part, it's also going to be based on what you think the differentials are. and also based on their comorbidities. So if they have underlying CHF, underlying COPD, you would get your testing based off of that. If you think it's a stroke that caused it, you would get your CAT scans or activate your appropriate pathways based on your institution. So now we're going to talk more about the treatment for it. And so in general, we kind of think about it more in broad categories. The treatment will start off with supportive care. Then you're going to be thinking about anti-thyroid drugs, thinking about using beta blockers. You might even be using steroids. And then most importantly, often is going to be treating the precipitating event. So in general, when we say supportive care, it's things that we already know. IV, O2 monitor. A lot of these times these patients could be febrile, so you want to definitely work on cooling them, giving them IV fluids. A lot of times they may also have folate deficiency secondary to hypermetabolism, so you also want to think about repleting their folate, think about repleting their thiamine, giving them multivitamins. And then they might also be hypoglycemic, as we mentioned earlier, so you may also want to consider giving glucose. Then the second step is going to be anti-thyroid treatment. And for the most part, we're thinking about two main drugs, methimazole as well as propylthiouracil. So with methimazole, which is abbreviated as MMI, that's going to be the first choice for almost anyone. The exception would be a patient who is pregnant and in their first trimester. The reason why methimazole is actually contraindicated in the first trimester is because it's linked to congenital abnormalities, which is associated with first trimester organogenesis. So otherwise, if they're not a patient who's in the first trimester pregnancy, then methimazole is going to be the first choice. Otherwise, it's going to be propylthiouracil in those cases. And we'll briefly go over the doses, which many of us will probably end up looking up at the time, but I'll say it once here just so that people are familiar. So with methimazole, we'll start off with like 40 milligrams PO loading dose, followed by 25 milligrams every 4 hours. If their patient cannot take it by mouth, you can also give methimazole via the rectal route, but that would have to be crushed in an aqueous solution. When we're thinking about propylthiouracil, the loading dose would be about 600 to 1,000 milligrams PO, followed by 200 to 250 milligrams every 4 hours. And just as an aside, the reason why propylthiouracil is not used as the first choice in a lot of cases is because it's really associated with agranulocytosis as well as fulminant hepatic necrosis. So there's just a lot more considerations when you're thinking about PTU, which is why methimazole is usually the first choice in almost all cases. So then the next step is inhibition of thyroid hormone release. And the way we're going to do that is more so with iodine. And so whenever we give iodine, we have to remember that we have to give it at least an hour after we've given either methimazole or propylthiouracil. And so whenever we're giving iodine, we can do it a number of ways. We can do Lugol solution, and you can do 8 to 10 drops PO every 6 to 8 hours. We can give potassium iodide, which would be 5 drops PO every 6 hours. If the patient is allergic to iodine, other things we can think about are things like lithium carbonate. And then when we're thinking about beta blockers, that's going to be more so for treating these patients who often come in with tachycardia. And so you can do that a number of ways. And though many of us are familiar with propranolol, we can do 1 to 2 milligrams of propranolol and give that every 10 to 15 minutes until we get the desired effect. Other things we can choose are esmolol. We can do a loading dose of esmolol at about 500 micrograms. And then we can do a maintenance dose of esmolol thereafter. The thing to think about with beta blockers is that we have to be careful in patients who have underlying CHF or bronchospastic disease. And so the next thing is going to be preventing the peripheral conversion of T4 to T3. And we're going to do that primarily with the use of steroids. And so we can do it in a number of ways. We can use hydrocortisone 100 milligrams IV initially. Then we can use hydrocortisone 100 milligrams 3 times a day until they're stable. Or we can use dexamethasone 2 milligrams IV every 6 hours. And in addition to preventing the peripheral conversion as well as anti-thyroid hormone and beta blockers, it's going to be treating the precipitating the event. And then the definitive therapy would be things like either surgery if needed or radioactive iodine ablation therapy. But in almost all those cases, we wouldn't be doing those things. We would be, of course, getting our consultants on board. And another thing I wanted to mention, this would be more honorable mention, would be things like levothyroxine overdose. So it's not something that we necessarily see all the time in the emergency department, but if you do have a patient who presents after taking, more levothyroxine than they normally would, things to remember is that symptoms may not actually occur until at least 24 hours or more. There's even been a case report of like a 70-something-year-old woman who took an extra dose of her levothyroxine, and she had to come in 2 or 3 days even after the ingestion for her to be admitted. So things to think about for levothyroxine: usually if you worry about it, if they've taken more than 10 milligrams of thyroxine. In kids, they may actually start to show some symptoms if they've taken 5 milligrams. And a lot of times the symptoms that you'd be looking for are things that we talked about before. Things like they might have tachycardia, they might be diaphoretic, they may have palpitations, they may present with other signs and symptoms of thyrotoxicosis and thyroid storm. In general, the treatment's not standardized. There's not a whole lot of guidance. What you can do is they present acutely is you can give activated charcoal for acute ingestions, and the dose would be about 1 gram per kilo in children, or you can start off with 50 grams in adults if the patient ingested either greater than 10 milligrams in adults or greater than 5 milligrams in kids acutely. All right, so next thing is we're going to move in more into hypothyroidism. So we're going to touch base more on some of the high yield topics or diagnoses that we don't want to miss in the ED. So we'll first talk about the difference between primary and secondary hyperthyroidism. So with primary hyperthyroidism, we're thinking about a decrease in the production of thyroid hormone at the level of the thyroid gland. And the most common cause of primary hyperthyroidism here, especially in the United States, we're going to be thinking about things like Hashimoto's, like autoimmune causes. Other causes could be things like secondary hypothyroidism, would be like panhypopit or pituitary adenoma. But what differentiates primary hypothyroidism from secondary is more so thinking about the pituitary gland and the hypothalamus. So at the pituitary gland, you would think about decreased secretion of TSH or decreased secretion of TRH from the hypothalamus. And so other causes of secondary hyperthyroidism, things like pituitary adenoma, you also think about infiltrative causes such as sarcoidosis or hemochromatosis, or if they've had a history of brain irradiation. And then once again, you always have to think about drugs. So if the patient is on amiodarone, if they're on lithium, if they're on iodine, that can be a cause of secondary hypothyroidism. So now we're going to touch briefly more on the signs and symptoms of hypothyroidism. And so it could be a number of things: hair loss, fatigue, they might have loss of the outer third of their eyebrows, they may have pallor, they may have constipation, infertility. If you're getting an EKG, you might notice that they might be bradycardic. They may have non-pitting edema or cool, rough, dry skin. The things that we don't want to miss is going to be more so MYXEDEMA crisis. So MYXEDEMA crisis would be signs and symptoms of hypothyroidism plus mental status changes, as well as hypothermia. And hypothermia actually is so common in MYXEDEMA crisis that if the patient has a normal temperature, you should be thinking about potentially infection. So once again, we're thinking about how to work up some of these patients. It's really going to be based on our differentials, what we think is causing it, their underlying comorbidities, the precipitating event. When we're getting labs on these patients, other things to think about are things like, hyponatremia, and also thinking about things like hypoglycemia in some of these patients as well. So you can go ahead, you would get your CBC, you get your electrolytes, and you would do like your normal routine, but more so thinking about what other electrolyte abnormalities that you would have to think about in these particular patients. So now we're going to move on to the treatment therapy. So in patients who come in with symptomatic hypothyroidism, but they're stable, they're not in MYXEDEMA, coma, or crisis, you can essentially treat them with oral levothyroxine. And so for adults younger than 30, you can start off with 50 mics PO. For adults who are over 50 or have cardiac disease, initial doses anywhere from 12 to 25 mics. In general, I would suggest that we'd be doing all of these in consultation with an endocrinologist, but just so you're aware of what the starting dose would be for some of these patients. So now we'll move on more to MYXEDEMA crisis and how to treat it. And so the first part of the figure here, we talk about supportive care, which is on the right, and that's going to be what we normally would do: IV, O2 monitor, things that we already know. If the patient, is hyponatremic, you can think about water restriction. When they're hypothermic, actually the main thing is passive rewarming. We really don't want to do any active rewarming for some of these patients, because the underlying pathophysiology is really more so focused on their underlying hypothyroidism. So we need to first treat the precipitating event, treat them with thyroid hormone, and then do passive rewarming, and all of that will kind of help stabilize their temperature. Then we talk about thyroid replacement. And so a couple things you can do. You can start off with IV thyroxine. We can do 4 mics per kilo. And then the initial dose could be anywhere from 200 to 500 mics is the initial dose, followed by 100 mics IV in 24 hours. The other thing we can do is also IV T3, which would start up at about 20 mics IV, followed by 10 mics IV every 8 hours. There are some cases actually where the patients may have persistent hemodynamic instability, and you can actually decide to give both T4 and T3. But if you are going to give both of them together, the dose of thyroxine would be about 200 mics IV, and the dose of T3 would be 20 mics IV. And then, as I mentioned before, with the precipitating and comorbid factors, we'd be treating of course, their underlying diagnoses, or what we think is causing them, whether it's infection, whether it's trauma, whether it's a stroke. You would treat that based on your institutional protocols and also how you would treat them clinically. And so another thing to think about for some of these patients are pregnancy considerations. And so a lot of times women often at baseline will have, when they're pregnant, of course, will have an increased requirement of thyroid hormone. The reason for that is because of the increased rate of metabolism in the mother, and also because of the transplacental transport of thyroid hormone to the fetus, and it's essential for the fetus's development and maturation of their different organs. So if you have a pregnant patient who's already baseline has hyperthyroidism, the other thing to consider when talking to their consultants, like your obstetricians or endocrinologists, is that their thyroid hormone may have to be increased by about 30%. All right. So those were some of the high yield topics. So we'll just briefly go over a summary of what I wanted you guys to get out of it. And so when we're thinking about hyperthyroidism, we're thinking about more so thyroid toxicosis and thyroid storm as the diagnoses that we don't want to miss. So the main thing is going to be evaluating and treating the precipitating causes. The diagnosis is actually largely clinical, because in some institutions you may not even have the thyroid back right away. And if you have a high suspicion for it, you really want to go ahead and try to treat the precipitating event, give them supportive care, things like propranolol, steroids, iodine, antithyroid hormone. And another aside is to remember that a low TSH is not diagnostic. You definitely want to have a T4 when you're trying to figure out whether it's hyperthyroidism primary or secondary. And then with hyperthyroidism, the main thing, at least for us as emergency medicine docs, is MYXEDEMA crisis or MYXEDEMA coma. And the main thing to remember is that they are going to have signs of hypothyroidism, but they're also going to have mental status changes and hypothermia. And if they are not hypothermic and they have a normal temperature or hyperthermic, you need to be thinking about something else. Once again, the treatment is going to be supportive care, thyroid replacement, vasopressors as needed depending on how sick they are. And that's all that we have for today. Thank you.
Thank you, Dr. Albert. Would you mind if I asked you just one quick question?
Sure.
When it comes to the diagnostic piece of it, you mentioned that the screening test is initially the TSH, but you need the T3, the T4. Is there an advantage to one versus the other, or even like a pitfall, like a circumstance where you couldn't trust a T4 and needed a T3, or vice versa?
It depends too on the patient's history, because in general T4 and T3 are bound by albumin and different globulins and transthyretin. So I think in some cases, if the patient has underlying issues where their albumin might be lower, you may not necessarily be able to trust your T4 or T3. Other things that you have to think about when you're looking at T4 and T3 is that, as you mentioned before, T3 can be elevated from so many other causes, not just the thyroid gland. So a lot of times, I usually actually would kind of compare both. But just to remember that T4 is more so a product of the thyroid gland, and T3 could be elevated from so many other causes.
That's really helpful. Thank you.
All right, no problem.
All right, thank you very much.